and which will be in the realms of neuro-oncology, an interesting case for discussion. And then the second case by Dr. Matheus Recht, who will be presenting on a skull-based case, and it will also be very interesting for discussion in a number of different details. So good morning, everybody, and for the sake of time, so we can have the two presenters working today, let's have Diogo starting. So Diogo, please. Good morning, Dr. Q.
Good morning, JP. Thank you for leading this morning's conference. I'll be coming in and out since I'm getting a bunch of phone calls and a couple of meetings in between, but thank you everybody for being here, and take it away, please.
Absolutely. So Diogo, for the sake of time, let's start with you.
Sounds good. So good morning, everyone. So I'll be presenting the first case, and then Matheus will be presenting the second case. I call this case a curious case of deception. As you'll see, things are not always what they look, and I think this is an interesting case with some teaching pearls that worth discussing today. This is the team that was involved in the care of this patient, and I just wanted to thank everyone for their help and the discussion and the teaching pearls that everyone provided that, I think enhanced a lot of presentation. So we're going to have
Can I snap a picture of that title? I love that title. I'm just snapping a little picture right here. Boom. I like it. Sorry.
So we're going to have neurology with Dr. Sebastian Lopez, but also neuro-oncology, as you will see. So that alludes already a little bit to the debate we're going to have with Dr. Barbanel, our radiation oncology, Dr. Sepsi, Dr. Genta, Dr. Bajakshi, radiology with Dr. Murray and Dr. Faiz, and of course, Dr. Q and Dr. Almeida. So this is a 36-year-old female who was in her prior state of health until early this year, was first evaluated at another hospital, and she started having these complaints of jerking on the right side of her face. That was diagnosed at the time as a focal seizure. That she had actually periods of secondary generalization. She was placed on Vimpat, 100 milligrams BID. This is important though, she didn't have any prior relevant neurological history, any other prior episodes that were suggestive of anything, which is important, especially in a young female. She already had outside imaging by the time she came to Mayo that showed multiple foci of T2 hyperintensity, as I'm going to show in some of the images I had, and she was already on steroids. So the first time she was seen here on examination, she was mostly intact, but she did have weakness on the right side of her face. And she kept having, again, the complaints of jerking, but on top of the jerking, which was associated with a seizure, she did have some weakness. Otherwise, she was mostly intact. And here I have the first set of images that were available to us. And I'm going to go here on the left with a T2 axial. As we can see, there's two large T2 hyperintense lesions. One of them that seems to be coming from a cortical base at least, but either medial frontal gyrus or even precentral. And there's one more posteriorly that you can see there that is post-central. And I'm going to go into a little bit more detail into this. And of course, I know Dr. Murray will also be joining us to discuss, but I just wanted to show here that on a T1 post-GAD, you don't really see any enhancement at this point. And on the DWY, you can see that this lesion seems to be restricting diffusion, which is important. Now, importantly, we do see a lot of these other lesions a little bit all over the place. You can see here on the far left, in the cerebral peduncle in the brainstem. You can see here in the corona radiata in the middle, and there's another one here on the T1 in the corpus callosum. So this really seems to be suggesting something, and I think Dr. Murray is also in the line. I don't know if you want to discuss further, Dr. Murray. We're discussing this yesterday, that why, it suggests something, but I don't know if you want to add a little bit more detail at this part. I do have more images coming up.
I'll let you proceed, and then I'll interject later. You're doing great.
Okay, perfect. So one of the things that I think is worth mentioning also is that, as I was mentioning, this is a lesion that is restricting diffusion, and you'll see in more images afterwards that keeps being the case. So just to make a point of summary at this point, we have a young female with facial weakness and seizures, multiple T2 hyperintense lesions along the white matter, but also two large ones that seem to be coming actually from a cortical base, not white matter. So a little bit of a mixed bag, but the two top differentials at this point from the team's conclusion seem to be either demyelination, and we can always have tumefactive demyelinating lesions like those two large ones. And that would explain why we have white matter lesions. It does fit with a young female. However, though, it could also be a neoplasm. And this is really the debate we're going to be discussing a little bit more in detail, because there are things that do point towards a neoplasm. As you can, seizures are not classic with, the myelination, and also those two lesions seem to be coming a little bit more from the cortex, not so much the white matter. So the decision at this time was made to admit the patient and do quite a comprehensive workup with neurology leading, more in imaging, including neuroaxis. So we got also cervical thoracic lumbar. The steroids were increased to 4 milligrams BID. We got a lumbar TEP for CSF analysis, and she was also placed on a PLAX trial. And as you can see, this is imaging that was obtained now throughout admission, and things seem to have changed a little bit. So you can see here on the left, T1 post-GAD, that now the lesion seems to enhance. And there's an enhancement which is patchy. It's not just, over the leading edge, even though there's a little bit of a rim, but you also see enhancement here all the way to the surface and the cortex. I have here a sagittal just to show that as well, that you see really patchy enhancement. And here a coronal, just so we can see this in a little bit more detail. And I also have here the T2s, where you can see that the lesion seems to be now developing almost like vascularization or abnormal vascularization. You see a lot of those vessels there inside the lesion, which would also be very atypical for a demyelination. And here just the T sagittal is showing that the lesions seem to come almost to the IFG, which will also be important for surgical purposes. And importantly, I have here on the right that it still is restricting diffusion. And this really just seems to be a little bit atypical for demyelination. And just to make a point of summary here now, at this point, the CSF had been obtained. It was negative for early clonal bands. The patient did not respond to the PLAX trial. She was still having some, not real breakthrough seizures, but a seizure-like aura. She was worsening. Her facial weakness was worsening. There's steroids had been increased, but it was still not really improving. So things started now not pointing so much to the demyelination, but there was still quite enough of a question, as you'll see. And I don't know, Dr. Moy, if you want to add a little bit more about this from your perspective.
Sure. Can you go back to
Absolutely.
that and show the that T2 axial, go up to the kind of the tumor involving the right there, that picture right there, and look at that. That is a picture of a tumor. It's infiltrative. Look how expanded that gyrus is. Go up and down so you're going to see the hypervascularity. Go up and down
Absolutely.
a little bit right there. And then you go back. It actually you can trace the MCA. So that is a picture. And then you have patchy enhancement. And the enhancement pattern, I would say, is gyral. It's patchy, but it's involving those expanded gyri right around those vessels when you look at it. You also have restricted diffusion. So what you can say, this picture here, let's take out the other white matter lesions, which are red herrings. And this picture here is a multifocal high-grade glioma that's hypercellular based on the restricted diffusion. And it's a high-grade glioma, multifocal in all likelihood. Now, what makes this such a confusing picture, you can have tumefactive MS and they can look very mass-like. They have more of a white matter vector. I think a vector analysis is real important. They do not infiltrate the cortex and massively expand the cortex. Also, you're going to typically see white matter more. It can involve some gray matter as well, but you're going to see that leading edge of enhancement, not this patchy gyral enhancement. Now, what makes this case difficult is that those other lesions you show, they look like MS. They really look like MS, and us as radiologists and as physicians in general, typically try to unify instead of give two pathologies, which is what this looks like, is two pathologies. This, if you take out the other white matter lesion, this is a multifocal high-grade glioma. So it is somewhat confusing because I think we try to unite these diagnoses, and I think that's what's causing, that's what led to some confusion in this case. But this is a good example of the imaging of what should be a infiltrative multifocal adult type high-grade hypercellular hypervascular glioma. And it's also interesting that the patient had no symptoms of what we would think of demyelinating disease prior to this. So could this be a radiograph? Could the other lesions be a radiographic like we talked about yesterday, Diego? Could they be a radiographic isolated syndrome where you have MS-like lesions but no clinical manifestations, and they're at a higher risk of developing MS down the road?
Yeah, absolutely. And I see there's also a question from Gaetano.
Hey, Diogo, I don't know if Dr. Lopez is on the line, but I mean, of course, hindsight is 2020. I think you really, I was on the service with neurology, and there was a lot of thought that went through this case. I don't think you showed it, but when we sent the CSF, NMO mug also was negative, but we got the kappa chain, and some of those tests we send them to Rochester, so it takes some time to get those back. We got the kappa chain, and they were slightly elevated. And I remember the discussion with Dr. Lopez. We were waiting for the oligoclonal band, which is the result that follows when you get the kappa chain. And he said, I'm sure it's going to come back positive. And then we were all very surprised when they came back negative. Another thing, the patient also didn't have just a weakness and the facial weakness and the right arm weakness. She also had some pretty remarkable dysarthria, sorry. So that was also another symptom that she had presentation. And she still has, last time I saw her. So, I mean, hindsight is 2020, but it was a very complex case. Then we started there, not just a trial, but she got like the 5 full sessions of Plex. And at first she was improving. So we thought that that was actually the diagnosis. But this is a very complex and challenging case.
Yeah, thanks a lot. We're also going to show that with the neuropsych. And I see that Dr. Barbanel is also in the line, and Dr. Hammock. I don't know if you want to discuss anything also at this point.
Yeah, so to make matters murkier in the beginning, so I met her by video at first, which always makes things tough. But then when I saw her, I had the initial scan, and then the second non-contrast scan that showed this new, what looked like a new T2 hyperintense lesion in the subcortical white matter. I couldn't tell if it was enhancing or not because there was no contrast. And an outside report that said, new T2 hyperintense lesion likely due to treatment, which was ridiculous because she hadn't been treated. So that got me thinking down. I started looking closer and I saw that corpus callosum lesion. I saw the pontine lesion. And I said, so I started taking my MS history and I said, how about the bowel and the bladder? And she said, yeah, I can't feel the need to urinate anymore. I just urinate because I know it's time. She was timing her voids. I said, okay, this sounds like a multifocal process. This is very unusual. Many of the features of the tumor, I totally agree, looks like a tumor, but there was too much weirdness going on. So that's what really sent us down this path. The patient, this new lesion showing up, not being able to characterize it with contrast, reporting a sensory myelopathy, very classic for MS. And then she came in and she had a lesion there. It wasn't enhancing, but also could have been hyperacute. We looped in our tumor-effective MS expert up in Rochester. We looped in our experts down here, and it just kind of became this whirlwind of confusing variables. And then we had our own MRI that was reported as being overall fitting with demyelination. That's what the report said. So I'm really glad you're presenting this case because it's so murky. I did find myself getting anchored, very much anchored. I wanted this to be demyelination. I wanted to be right. Thinking about my ego. I also wanted her to not have a tumor. So these are things we need to reflect on throughout cases. To any of the trainees out there, you got to always think, what's driving my thought process? You got to try to remove things that are unscientific. So thank you.
Absolutely. And I see Dr. Murray also. Sorry, Dr.
No, go ahead, John, and then I'm going to go ahead and just.
Okay, I think another point here is where are these tumors located? Because they're very eloquent. And I think that needs to be described and point out. Number one, the more anterior one goes down to the inferior frontal gyrus, and there was a functional MRI which shows Broca's just anterior to it. I think it was involving. If you go to the sagittal, do that sagittal.
I have the functional here. Just
yeah, you're going to see it's going down to the pars opercularis. See it right there. There you can see Broca sitting right in pars triangularis, right where. So this is going right up to the language. And the other point is it's also involved in the postcentral gyrus, but as you go laterally, kind of getting towards the tongue or so, you definitely are getting some precentral gyrus as well laterally. So very eloquent. You got motor cortex, you got it right up against Broca's. So very eloquent areas as well. I think that's, and look at that gyrus. It's just hugely expanded. You can see it right there.
Absolutely. Thank you so much, Dr. Q.
I was just going to say, if you go back to the T2, the axial, and the way that I think about this is why I also asked David and Dr. Lopez, Dr. Barbanel, Dr. Lopez, a radiologist, to look at. If you look at that scan and you say, this is going to be a chit chat. This thing comes to the surface, and you should be able to see it. And I am wrong 50% of the time. I can flip a coin, and as you will see from the intraoperative images, you look at this and you're like, oh my gosh, that looks like normal brain. Where am I going to enter this? Am I going to give this patient a final, a complete deficit? Am I going to hurt their language, their motor function, everything that Dr. Moore just mentioned? And I discuss, a lot of these cases, and I don't know if Dr. Savsovich is on the line or not, but there's a lot of thinking that goes on. Myself, JP, Dr. Savsovich, Kai, we're all constantly thinking about this, because you may think that it is going to be, a chip chat, and then you go in 50% of the time I'm wrong. The other 50%, yes, it looks like, oh, this is really wide. We're going to come around and we're going to find a pseudoplane and gyros to gyros, and then you do a resection. But unfortunately, that's not the case all the time. So, and that's why it's so good that you guys are discussing these cases and going back and forth through a differential diagnosis and having honest discussions. And the images are beautiful. But despite of that, as Dr. Mura said, even in the 7T, you can predict sometimes whether or not this truly going to come to the surface.
Absolutely. Thank you, Dr. So, like everyone, I was mentioning here, a lot of debate, and as Gaetano also alluded here, that we had CSF and the oligoclonal bands were negative. There were mildly elevated light chains, but in discussions with Dr. Lopez, in retrospect, this could also be a false positive, but nonetheless, a lot of question. And here, just to make a point of summary for the justification of what we're going to do next, even that there is a significant enough potential suspicion for a glioma, but still nonetheless the possibility of a concurrent demyelination, a decision had to be made, and there were several options. One, which was to wait and get more scans, but the patient was worsening. And as you are going to see in a slide that we have of neuropsychology, her speech was getting worse. She was having a lot of dysarthria, weakness on the right side. We could always repeat the CSF workup, but that was thought to be low yield. So a decision was made to either proceed with a biopsy to get tissue diagnosis or actually surgical resection. So the plan was to have an awake cranie with the patient with neuropsych with speech mapping, do an excisional biopsy to get a frozen path, and then depending on pathology, and if it is conducive, to then potentially do a more of a resection. This is just a video that Dr. Sepsi was kind enough to provide to us. And I hope you can hear the sound, but if not, I'm just going to go ahead for the sake of time. The point here is to show that the patient was having a lot of struggles, even at baseline, with picture naming. Her speech is slow. She's having issues with naming, and this was at baseline. So there was actually a question here. I don't know if Dr. Sepsevich is on the line, whether or not we could even do this awake. And he was actually telling me that in many other centers with a patient like this, many professionals would not do it awake because the patient didn't seem to be a good candidate. And Dr. Sepsevich, I don't know if you're in the line, if you'd like to comment. I don't think he is. So in the meantime, I'm having here the fMRI. We already discussed a little bit, but as you can see, the lesion comes on the sagittal all the way down to IFG, almost involving pars opercularis. So that could justify a lot of the speech issues the patient is having. And here on the right side, I have fMRI motor. And like I was reviewing Dr. Murray, it doesn't seem to be really involving the lesion, but it is definitely encasing. So a lot of eloquence surrounding the lesion. And I don't know if Dr. Almeida, you'd like to say anything further before we go to the surgical video. Okay, so with this in mind, as you can see here, the patient was brought to the operating room, position supine.
If I may just add one comment. As you see here in this case, considering the complexity of the differential in the location, we even like with the anatomical MRI, so to say, we had a lot of concern in terms of functionality of this patient who already had significant expressive aphasia, and also the weakness that was more prominent on her right side of the face, and but also some weakness in her arm. So we have two areas to be considered for biopsy, the one that is enhancing, of course, so it's more likely a target. And additional to that, that is the left frontal one, which is also there where the speech is already quite significantly compromised, which makes mapping more difficult, but also would, be less of an issue if we have to proceed, just with a small biopsy so we can get diagnosis. So we were discussing, how we're going to approach, which area we're going to biopsy, how we're going to do that. Of course, you're going to see that in the craniotomy, we actually had somewhat of a sizable craniotomy to expose both areas, but we went with a game plan to biopsy that left frontal because of the details that we're discussing at this point. And then the functional MRI helps us to of course to dictate that, but the symptomatology of the patient and the enhancement also as well.
And
I see Dr. Vargas. Yeah. Dr. Vargas.
Yes.
Good morning.
Thank you. Thank you. Good morning. Very interesting case and multiple lesions. I wondering, spectroscopy will help in this case, for example. I don't know if we have available or not, or if we can have an opinion of the radiologist that in this kind of cases, I think that if we are thinking in a high-grade glioma, spectroscopy will give us some other point for decision that go and take the lesion. So that's my question.
Yes, potentially it could. I'm not a huge fan of spec. We do a whole lot of spectroscopy here because it sometimes can be confusing. I think in this case, it could have been helpful because I think that is high grade. I think yes, it could have been helpful. In my opinion on the imaging, and I know, and I did not read the diagnostic, I did read the planning study. That is a glioma until proven otherwise, just based on the imaging. Now you have the caveat that you have these white matter lesions which do look like MS. There's no doubt. So you kind of got two processes going on. But to answer your question, in this case, although I'm not a huge fan of spectroscopy, yes, I think it could have been helpful to tease those two out.
Thank you, Dr. Murray and Dr. Vargas. So patient was brought into the OR, like Dr. Almeida was saying, we have quite a large exposure because we were ready in case the frozen path came as a high grade to do a more comprehensive resection. So as you can see, we're going to turn the bone flap. I'm going to move a little bit expeditiously just for the sake of time. Patient was then awakened, as we always do here. You can see the exposure of the dura, quite a large exposure. We used the circular grid just for passive mapping, which showed no epileptiform discharges. At this point, the patient started being awake, and you can see here she was continuously being tested by Dr. Sapsevitz. Interestingly, the patient did have some worsening initially, which was worrisome. But as you're going to see, as the surgical resection actually started, she improved, which is actually very interesting finding. And you know, I was reading also Dr. Q's notes and discussing this with Dr. Barmel, and we were wondering if potentially even some of those epileptogenic foci were resected, and that's why she had some improvement while the resection was ongoing. And we, sorry, go ahead, Dr.
I'm just gonna, the next figure that you were going to show, just the brain. Just look at how beautiful the brain is. If you were thinking that this surface was coming, I mean, this lesion was coming to the surface, you can actually see the brain. I mean, it's just like, how do you choose a window, right? And you see this massive, you know, lesion. And a lot of the patients, and I always make a point of telling the patients, they see the MRIs. We always show them the MRI. And I said, when I look at this and I open the brain that is overlying this monster looks absolutely beautiful. You know, and if I try to predict that there's something that comes to the surface, I'm going to be wrong 50% of the time. And this is important also, you know, as Dr. Murray mentioned, these are very complex cases, a lot of eloquence, a lot of function, and a patient that can be our daughter. I mean, literally can be my daughter, and she's in her, you know, early 30s, and absolutely dangerous. But that's good. Thank you, Joe, please.
Absolutely. So the patient did have some improving, and that was actually a very interesting finding. I was discussing this with also Dr. Sapsevitz, and that allowed us, because at this time we got the frozen path that did confirm this seemed to look like a high grade. So went back to the OR to now try to get as much as we could safely. And luckily the patient improved from a neuropsych perspective, and she was very cooperative, being able to name, and she was doing very well. So, you know, Dr. Q and Dr. Almeida were able to push it. And until the end, when she started having now a little bit of a worsening, and at that point, a decision was made to stop the resection. But as you're going to see here, this is just some images of our tissue collection. And here you can see that now we have way more than just a biopsy. We have a corridor, and you're going to see that all the enhancement was resected. And at the end, because the patient did have a little bit of worsening, it was felt, you know, it's better to stop here. And for the sake of time, sorry, go ahead.
Yeah, I was just going to say, keep going, but one technical point, and then maybe David can provide some insight. We did a nice craniotomy. I always like to, and this is what I learned from when I was a resident, I like to be prepared for in the future. If she's going to need another craniotomy, where we understand now over time, there's plasticity in the brain, and some of these functions get shifted away and they move away. and there's an opportunity to come in and do a much more extensive resection, we're already set with the dural open and with the craniotomy and things like that. But also to be able to have a good exposure, and because I wasn't sure where we were going to have a window. We've been there so many times, and we think we're going to be able to come right here, and we realize there's so much function that we're trying to figure where we're going to poke a small little opening on the cortex to be able to get into the brain. So we'd like to be just prepared, and prepared not only for the case that we're going to do there, but also for the future. So just technical aspects of the craniotomy, the opening, because some people say, why don't you just do a little tailored craniotomy this way? Because we think that these patients are going to need more than one surgery, to be honest with you. All right.
Absolutely. Thank you, Dr. Q. Dr. Gentoft, I don't know if you want to comment on the images.
Sure. I don't see them yet.
I am sure.
Okay, there you go. Circled is microvascular proliferation, and the arrow shows a tiny focus of necrosis that's present. So these features indicate quite a high grade. And in addition, you can see how hypercellular the tumor is. If you go to the next slide.
Can you see the screen, sir? There's two circles highlighting mitotic figures.
Yeah, it's for some reason there's a lag on my end. So the tumor was mitotically active. And then if you go to the IHC slide, you can see that the tumor is IDH negative by immunohistochemistry. ATRX is retained. P53 is positive, and neurofilament highlights axons within the tumor, which indicates a infiltrative growth pattern. So we know that this is, in the old days, we could have just called this a glioblastoma outright. But since the patient's under 55 years of age, we have to wait for the molecular testing to come back to see if it's IDH wild type or not. And I would put money on that this is going to be IDH wild type, but the molecular testing is still pending.
And the patient did well. Sorry, go ahead, Ricky.
I was just going to say, Mark, what do you think? Because I've seen a lot of IDH mutant also have this sort of radiographic, finding, but what makes you think that this is going to be a wild type?
Well, the reason I think that is the ATRX is retained, because typically, and it's not 100%, but typically if it's IDH mutant, the ATRX will have a loss of expression. And in this one, it does not have that. So It makes it very likely. It doesn't make it 100%, but it makes it very likely that it'll be IDH wild type. Hopefully I'm wrong.
And Dr. Murray, from your side, from the radiology, because you and your colleagues are getting better and better in predicting this. Your thoughts as to when you look at the imaging?
Well, when you look at the imaging, and once you make your mind up that it's a neoplasm, it has features of a high-grade neoplasm. What I didn't see, what we used to traditionally look for to say this is a glioblastoma, is necrosis on imaging. That was what you did not see jump out on the imaging. That was very small. Now, what you did have is, number one, you had restricted diffusion. I mean, really restricted diffusion, which corresponds to all those little blue cells. Okay, those are all, water can't move when there's a bunch of little blue cells sitting next to each other. Okay, so you had hypercellularity, you had those really prominent flow voids. So you had, that goes along with the hypervascularity, those prominent vascular that we just saw in the pathology, and you had enhancement. So remember, in the setting of an infiltrative astrocytoma, we're not talking about circumscribed. When you get enhancement, you're bumping up in our mind to a grade 3, grade 4. So you had this feature is a high grade glioma by imaging by those criteria.
Gotcha. Thank you.
So the one last point that is worth also discussing, I don't know if Dr. Barman and I also see Dr. Hammock you'd like to discuss, is now that we have this patient with this diagnosis and potentially need chemoradiation, but has a concurrent potential diagnosis of at least a RIS or even potentially an MS if she becomes symptomatic and has dissemination over time, how that changes the adjuvant therapy, if it does change at all, what we do next. And I don't know, Dr. Barman, if you'd like to comment on that.
From my perspective, it wouldn't change anything that I do. I would want to make sure I looped in Dr. Lopez again to see if he thought we met criteria to start her on disease modifying therapy. In case anything that we were doing, especially the radiation, might be risky, but with just how aggressive and severe this diagnosis is, I would stick to the usual protocol.
Thank you, sir. And that was it from my side. I don't know if anyone else has any other questions from this case.
My only observation, David, and something in that this is where having Julie here and some of our colleagues and also Dr. Lopez, is that she is definitely improving. And we didn't do much as far as the surgical resection, to be honest with you. I mean, we did a nice resection, but it wasn't any major decrease on the tumor burden per se. So there's a possibility that she may have two things going on, and obviously that may affect the way we think about this. So I'm asking our team to just be thoughtful of that, because if you go and see her, even her facial drooping has improved significantly over the past week or so. And I don't think we did enough in surgery to be able to account for that improvement. That's my only observation. All right.
All right. So next we're going to
Thank you for that insight. That's really